spent years and years and years putting thousands of patients into menopause, either with chemotherapy, Lupron injections to shut down their ovaries, and or other medications to block the estrogen from getting to the receptors, right? She gets the breast cancer at 38 years old, and it's triple negative. And we cure it, and it's 5 years later, and it's not there, and she's miserable with her, menopause symptoms. Can you give her hormones? Well, I just said yes a couple minutes ago. But the other question is, she's still at a significant increased risk of getting a second breast cancer. But I don't think estrogen replacement therapy causes breast cancer. But I do think that if there's already an abnormality that might be hormone receptor positive, you could be pouring gasoline onto the smoldering fire.
You're a smart, educated human who wants more from healthcare. And I'm Dr. E, the NP with a PhD, and I'm committed to making sure you never experience medical gaslighting again. This is the Medical Disruptor, the show where MDs, NPs, PAs, and researchers tell us how they broke the rules because they couldn't find answers in the system they came from. My guests are all science-trained innovators who chose the truth over tradition. Real talk, real science, no gaslighting. Because when you've been told the same story long enough, you start to believe it. This is a show where we help you challenge your own medical beliefs, especially the ones that were never yours to begin with. Today's guest is Dr. Tiffany Troso. She didn't abandon conventional medicine. She evolved it. From surgery to strategy, she's reimagining what it means to heal, lead, and disrupt. If you've ever felt like you're meant for more than the checkbox version of care, this one's for you. Dr. Tiffany Troso, thank you so much for being here. Super excited to have you.
Thank you so much for having me. I'm so excited to be here. I'm so thrilled that you're taking the time to meet me.
Oh my God, of course. So a little bit of a different disruptor, a disruptor nonetheless, right? So many of our guests are classically trained, clinically trained, and then something happens alive and then they go functional or integrative. You did leave allopathic medicine to a certain degree, but not necessarily to jump over into the deep end, although I think you are training to come to the deep end.
I'm starting now.
Sorry. But to become a patient advocate, and crazily enough, those are two separate things, being a doctor in allopathic medicine and being a patient advocate are crazily enough. So before we get into where you are right now, and
Sure.
So glad that you're doing this for women, tell us about your training a little bit and who you were before you jumped ship.
Sure. So I grew up on Long Island in New York, so you can probably hear the twang in my voice.
I know that's hard to me with my New York accent.
I know, right? Well, I thought it'd, help relate. So I grew up on Long Island. I was a soccer player, actually, and loved science. I went to Princeton University, and I actually played soccer at Princeton. And then I majored in molecular biology, which was super cool and cutting edge, and absolutely loved the science. I thought it fascinating. Meanwhile, fast forward 20-something years, it's hysterical. But the things that we were learning at Princeton in 1989 or what have you is now like in my kids' like middle school and high school textbooks. It's like basic stuff. I'm like, oh, wow, that was discovered in the lab across the hall from me. So anyway,
Wow, that's
science
so cool.
Is that cool? So science moves really quickly, obviously. After that, I took a year off and did some research in Manhattan and traveled, spent the weekends in the Hamptons and had the best time ever. And then I decided to apply to medical school. Anyway, and then there's all that. So I went to Cornell Medical School in Manhattan. And then I stayed there.
You're such a slacker, Princeton, Cornell.
So then I stayed there and I did New York Hospital for my internal medicine residency. And then I went all the way across the street to Sloan Kettering, all on York Avenue in Manhattan. And I did my fellowship there. And then I stayed on as an attending. So I worked for MSK in Manhattan for over 25 years. Most of my practice, though, was out on Long Island. I worked in the regional sites. So.
Wow. And just for our national audience, MSK it's just a facility only for cancer patients.
Right. Memorial Sloan Kettering Cancer Center. It's that and MD Anderson are considered the two best cancer institutions in the country. So very competitive facility, both to get into as well as to work in. I subspecialized in breast and gynecological cancers. So I've taken care of thousands and thousands of women with cancer.
So when you were taking care of them, what does taking care of them mean? Like, were you determining chemo? You're not a surgeon. I'm
not a surgeon.
Okay. I'm
a medical oncologist, which means that I'm the guy who gives the chemotherapy, the hormone therapy, I'm the one that would send people out, whether or not they needed radiation therapy, hormone therapy, what have you. I used to call myself sort of the point guard. the surgeon would do the surgery and then hand it off to the medical oncologist. And then sort of everything else happened in medical oncology. And so, all the other referral systems would mostly come from us. So we were the linchpin, so to speak.
So what happened in this experience? First of all, thanks for doing that, because it's a lot of studying to help women in the world. And so let's just take a moment to recognize that, because
Well,
it's a lot. Any provider, there has to be some sort of calling, and we put our lives on hold out at the service of others. So I just want to take a moment to acknowledge that about you. So something must have happened to you in this where you were like, I'm doing all the dues, but like something's wrong.
Yeah.
What did you notice?
Yeah. So, 25 years of doing this. And I just started 25 years. I know. And,
I have no idea how old you are, but how are you doing this for 25 years? Oh my God. Okay.
56.
Nice. I love.
Nice. Good. I got good eye cream. So I would be very invested in my patients, both in their cancer, in their lives. All of my patients know about my 3 kids. They all know that I, like to play tennis on the weekends, that kind of thing. I was very invested with my patients and getting to know who they were as people. And so over the years, that actually starts to wear on you, because when you have bad outcomes, or if you have a patient that, something not good happens to, you carry it with you. You really do. And, but the thing that I actually always had the most trouble with, because on the one hand, I'm treating and helping them with their cancer, and I didn't give them cancer. But the thing that I had the most problems with were the family members or the patient who were upset or disappointed or angry or confused about something, because I was always trying to give 110%. And if they felt that way, then I felt like I wasn't giving it. So I would do more, and I would try harder, and I would give more information.
You weren't giving it. What do you mean?
So sometimes and that gets back to what we were talking to before, patients would get upset or angry or frustrated, and often it was because of lack of information or lack of understanding. So, and oftentimes they wouldn't want to talk to their doctor, ask them the questions that would potentially clarify it, because some people are not comfortable asking their doctor questions.
Sure.
So I'm going to turn it around the other way.
Okay, quick break. If this episode is hitting home, just ask yourself this. Are you gaslighting yourself without even realizing it? I made a free guide called Self-Gaslighting Habits to Watch For. So if you're constantly second-guessing yourself in the exam room, this is your starting point. Check out the link in the description. Now let's get back to it.
I would commonly see a patient come in to Sloan Kettering, which is a big, referral center, and they were being treated at another local institution by a, well-accomplished physician who was doing fine. But the patient would come in and the husband would say, she just had surgery and we think she should get a PET scan, and they won't order a PET scan. And why won't they order a PET scan? And so we're coming here for a second opinion and we want a PET scan. Well, I'm sure you see the problem with that. Well, unfortunately, you have ovarian cancer or what have you, this particular patient. And if you order a PET scan, it's all going to light up, because PET scans go to areas of inflammation. And so their doctor was right that a CT scan post-operatively to get a new, lay of the land, so to speak, is actually the right test. But the patient didn't ask the question and the doctor didn't explain it. And so there was a miscommunication there, and they left the doctor to come to the Mecca to get another opinion. And I had to, okay. So it's a missed opportunity for a physician to educate their patients. But I have 1,000 examples like that.
It's a really good point. I just want to take a moment here. And also give you an opportunity to drink something. It's a really good point. I see this. I still practice primary care once a week, and there's so much frustration. I try to teach from my team. The frustration is not at you, but you take it personally. And a lot of it is, I just recently had someone who was like, I just don't feel well. I just want someone to MRI my brain. And I'm like, whoa, wait, what? We don't need to MRI your brain.
Right.
Well, why don't you just want to give me the thing? And I'm like, I want to give you more than that, but that's not the thing that you need. Let's calm down. But it's really, really hard, because when patients experience that frustration, they think it's you and you're in the way and you're gatekeeping. And a lot of times it's from a lack of information.
100%.
And, and in the world of reviews also, and then they go and they get a review, and you're like, if you just understood, I'm actually on your team.
Right.
to help. So interesting.
Right.
Okay, so I'm
Right.
understanding where you're at. Okay, so you
Right.
feel a lot of frustration with the system from a lack of understanding.
For lack of understanding. And the physicians don't have the time to really sit down and explain every single nitty gritty piece of why they're doing everything they're doing. In a perfect world, you can, but we can't. In academic medicine, where you're seeing patients, complex level 5 patients every 20 minutes on your own, like you can't explain every piece of biochemistry as why you're doing A, B, and C. You do the best you can, but I just found that the system was not conducive to the level of care that I really wanted to provide for my patients.
Yeah.
And so I have decided to break out on my own, and I'm doing a whole combination of virtual second opinions. So you can call me from wherever in the country with your medical records, and I will sit down and review every word of them with you so you understand it and can explain it back to me. I explain the treatment recommendations. If I don't agree with them, I'll tell them other options. I would never tell them that it was wrong. I would just tell them, like, here are some other options. I often will even communicate with the other person's doctor if they want me to.
This is great. Also sad and great. It's sad that, because we know that our colleagues want to do this, but they're constrained, they're handcuffed, right?
Yep.
I mean, yes, there are a few bad apples, but generally speaking, our colleagues are good humans,
Right.
want to do the best possible, but they have metrics that they have to meet. And so it's sad that that we can't get this in the system, kind of like you can't get functional medicine in the system. So much can't get in the system. But so wonderful that you're doing this and basically translating.
Yes. So I wrote 2 books. I haven't sent either of them out yet. I'm going to have to send you one to read for me.
Yes, please.
Let me know if you like them. So one is about my process of empowering the patient, basically how to walk the walk while you are under treatment for cancer, and how to communicate with the physicians, and how to organize yourself, and how to empower yourself. And the second book is like an oncology 101. It's a description of what happens to you from the moment you see something wrong until you're through treatment and survivorship. And so I go through biopsies and all sorts of things at a layman's level. Now, there are a lot of people in New York that maybe that's not complicated enough for them, and they're at a higher level because they're learning more on their own. But there's so many people that just don't know the difference doesn't know what an estrogen receptor is. It doesn't know what
a biopsy is.
Right.
Yeah, I have so many people.
So true.
What is that? And I'm like, okay.
Right.
Yeah, no, that's really good.
Yeah. So education, it's all about education and empowerment.
So it's interesting. Did you define the level that you're speaking to?
I would say it's probably high school level, which is already a little bit higher than most people recommend writing. People I've been told to write at like 5th, 6th, 7th grade levels. I would say this is more at a high school, maybe early college level. But the other thing I'm doing is I'm making an online course. And what I'm doing with that is basically using my books as outlines for the courses, and I'm going to teach them live. And then I'm going to get feedback, and I'll bring in old patients of mine, new people that I don't know, and just sort of be able to get feedback on, how is this landing?
Yeah. So our audience tends to be well-versed. And so I want to go, and this might be a Herculean ask, I'm not really sure because I don't know the answer, but on a really macro level, because you mentioned estrogen receptor, on a really macro level, what are the types of breast cancer that could be? Is that too much of a question?
Not at all.
Great.
Not at all. The first thing to explain that, you need to understand the receptors. Receptors are little proteins that are on the outside of the cancer cells. And I liken them to the old-fashioned, here's your house and here's your antenna, right? Sitting on the outside of the cell, and here's your antenna. And the antenna is looking for specific things in the bloodstream. So the estrogen receptor is a protein on the outside of the cancer cell looking for estrogen. And so estrogen's floating around in the bloodstream, and it binds to the receptor, and that causes the cell to grow, spread, live, what have you. Just like when the TV receptor got its signal, the TV would show you a picture, right? So it's just a positive effect.
So there 20 years, you won't be able to use this analogy for the next generation of
I know. I'll have to come up with something else, right? Nobody will know. I know.
Antenna. What's an antenna?
What's an antenna? but your Wi-Fi cord or your your the plug. I don't know the plug. So then once you know what a receptor is, then you need to know what the three different most important receptors are in breast cancer. One is the estrogen receptor, looking for estrogen, female hormone. The other one's the progesterone receptor, looking for progesterone, the other female hormone. And the other one is what's called HER2. And HER2 is a receptor for a certain type of growth factor that's in the bloodstream. And really, you don't need to know much more about that other than the fact that these three different types of receptors exist. So once a person has a breast cancer, we take a biopsy or a piece of tissue or what have you, and we study it under the microscope. And we take a look at which of these receptors are present or absent. And this is where I get to the answer to your question. So there's basically three major buckets of breast cancer. There's one that's estrogen receptor positive, that's considered hormone receptor positive, ER positive, HR positive. That's how people refer to it. There's some that have none of those receptors, and those are called triple negative breast cancers because the ER, PR, and HER2 are all absent. And the third type is HER2 positive cancer. And the HER2, as I said, was that growth factor that makes the cancer cells grow faster. And so if they're HER2 positive, there's a certain set of treatments that we use for that. And so it's hormone receptor positive, hormone negative or triple negative breast cancer, and then HER2 positive breast cancer. Those are the three big buckets.
So, okay, this was really, really, really helpful. And I know so many people are going, oh, God, that was already so good. Where can we buy her book? So I'm so excited for this. So which means, and obviously where we're going somewhere with this conversation, which means that if I have one of those cancers, to make it grow, if I have the hormone one and I have too much hormones or hormones at all, that will make it grow. Mm-hmm. If I don't have the one that has a hormone receptor, then
right, the triple negative,
my hormones are irrelevant to this conversation.
For the most part,
what is relevant to that type of breast cancer?
To triple negative breast cancer?
Yeah, what's growing it? Is it, do we know?
Yeah.
Is it inflammation? Is it just?
Probably a lot of inflammation. Oftentimes there's a genetic component. So the BRCA genes are often contribute to some of the triple negative breast cancers. There's environmental toxins, as you're well aware of. And then there are other growth factors. There are other drivers of that particular type of cancer. And we've actually also found in recent years that those triple negative cancers that have no receptors on them are quite actively treated by immunotherapy, which tells you quite a lot about the sort of the chemical milieu, so to speak, of where that cancer is, right? There's a lot, like there's inflammation and it's hiding from the immune system. And so immunotherapy has been very helpful in those cancers.
That's really, really important because I'm sure our audience is aware. So if we're using immunotherapy, then we're immediately thinking conversely, what are the things that are triggering our immune system to begin with? And then the third type, what is growing that?
The HER2. Mm-hmm. So HER2 is, again, it can have estrogen receptor also. So I kind of left that out for simplicity, but a HER2 cancer can also have estrogen or not have estrogen receptors. But if we're focusing, that's usually the HER2 component. That's what we call the driver. So sort of like you can have two things wrong with the cancer, or two abnormalities, and one of them is in charge. And so it's usually the HER2 is what we call the driver. And so those are growth factors that are floating in the bloodstream that are stimulated, not abnormally necessarily. What happens is with HER2 cancers that we get not just one or two copies of that receptor on the outside of the cell. The cell might be covered in those receptors. So all you have to do is sprinkle a little sugar or growth factor on it, and the cell goes crazy because it has so many mouths to feed, so to speak. Yeah.
So that, how do we treat? Like, if we're, you
target those HER2 receptors. You target them.
Okay. So, but I didn't get clear on like what are the things, because you're saying it's just there. It's unlike the inflammation or toxic burden or mm-hmm. the second type, unlike the hormones of the first type. Mm-hmm. What mm-hmm. is the thing that's driving it in the third type?
So I think that you would probably be better at answering that question, because I think that, what the question you're asking is not usually the same question that allopathic doctors ask. We treat once it's there, so to speak, and you help prevent it from getting there, which is one of the reasons I'm so fascinated with functional medicine right now. I think I think the real medicine in the future is going to be the two of these combined. We're going to have to meet in the middle somewhere.
Yes.
And yeah, exactly.
Yes. I think it's conventional medicine done right, because
Fair enough.
if you have a pathology, if we're here, pathology,
Yep.
we need the treatment. Oh my goodness, we need the treatment. But
Yep.
why we don't,
Right.
is where functional medicine lives. And so
Absolutely.
I love that.
So, I would say all of the toxins and inflammatory conditions that affect the other ones also would affect the HER2 positive cancers as well in terms of development. The difference here is that the cancer cell, while it was developing, something went wrong in the DNA. And so instead of being 2 copies of the HER2, all of a sudden it was duplicated, and now there's 6 copies of the HER2. And so now there's more mouths to feed on the outside of the cancer cell. And so that's why it's so energetic, right? Exactly. But yeah.
Fascinating. Okay. Whoa, my brain's going in 16 different directions. Okay. Before we started recording, and I think this is why it was really important that we did this grouping, we talked about hormone replacement therapy. We've done several episodes about hormone replacement therapy here. And
Warning, hot button topic. Hot button topic.
Alert. And, and to set this up, we kind of know, our audience knows that there was a time when hormone therapy was like the worst, but we've discovered that that's a myth and that's been debunked. And we're now in this new wave of the perimenopausal, postmenopausal awakening, and we should be on hormone get our life back. And I really do, like, with all my patients, I'm like, what are you doing? I don't prescribe them, but here's where you go. You don't need to suffer. Like, we don't need to, and shaming all these like old school docs that haven't caught up with the times and are really not taking care of the women right. So we're in this like perimenopause renaissance.
That's a great way to say it. The perimenopause renaissance. Sounds so elegant.
And the way you flipped your hair, now I want to flip my hair too. And so, and like really understanding it's a longevity play, and like Dr. Bredesen came out and said it helps prevent dementia. So like so many good things. But then you said, but there's a lot of confusion out there as to who can take it. So tell us about that confusion. What is the concern that you have?
So I'm going to tell you my personal opinion, and it's not necessarily the party line from whence I came. I would tell you in general, most oncologists are going to say no across the board to oral hormone replacement therapy. Where I grew up and was trained, and we did tons of clinical studies on vaginal estrogen. So we've been using vaginal estrogen in postmenopausal women with breast cancer, gynecological cancers for years and years, and we participated in the studies or created the studies that helped prove that that was safe. So I've always been a proponent of prescribing vaginal estrogen across the board. So the question or the problem is the patients that have hormone sensitive cancers, right? And so part of, as I was telling you earlier, part of the problem as a medical oncologist is that a lot of the treatments that we give are the component of them that makes it so effective are often getting rid of the estrogen. So I spent years and years and years putting thousands of patients into menopause, either with chemotherapy, Lupron injections to shut down their ovaries, and or other medications to block the estrogen from getting to the receptors, right? And so now to turn around, if you can imagine, to now have to turn around and be like, yeah, I just spent 10 years trying to cure your cancer, get rid of the estrogen. Here's some more estrogen. Here's some fire. Some fuel for that fire.
Oh God, the terror that people must feel.
But could you think, you have to, like, if you think of it in that perspective, like we spent our whole career getting rid of the estrogen and now they want it back. I'm like,
no.
So no, but that's not everybody, right? And so not everyone has, we discussed before that the 3 different major types of cancer. If your tumor doesn't have an estrogen receptor on it, then theoretically the hormones shouldn't be stimulating anything, right? There are some caveats to that. And I would still say that the majority of oncologists are not comfortable giving hormone replacement therapy across the board. I personally have offered it to patients that are in triple negative breast cancer, for example, which oftentimes women will get young. They might get it in their like 30s or 40s. And, so therefore go into menopause even earlier from the chemotherapy, and then are miserable. And so if there's absolutely no estrogen stimulation of the cancer that they have, theoretically it seems safe to give it to them. The one caveat that people don't always discuss when I talk to you about, all the people dancing and screaming on TikTok and Instagram about hormone replacement therapy is the fact that almost 50% of the time, if a patient, for example, had a genetic predisposition to having a cancer, and it might not even be a gene that we know about yet, but say that she gets a breast cancer at 38 years old and it's triple negative, and we cure it and it's 5 years later and it's not there and she's miserable with her, menopause symptoms. Can you give her hormones? Well, I just said yes a couple minutes ago. But the other question is, she's still at a significant increased risk of getting a second breast cancer, which may or may not be hormone receptor positive.
Because in general, because of her genetic predisposition?
In general, because she was a young woman who developed breast cancer that may have a genetic predisposition. So we do know, a lot of this is theoretical, right? But I'm just trying to talk through the arguments on both sides.
Absolutely.
So
our audience is amazing. It's smart. Let's tell them what you got to say.
So the argument is that, you have at least a 50% chance that if you were to get a second breast cancer, that one could be hormone receptor positive, and that you would then be fueling that one. So then there's arguments in the field that, and I do agree with this, that I don't think estrogen replacement therapy causes breast cancer, but I do think that if there's already an abnormality that might be hormone receptor positive, you could be pouring gasoline onto the smoldering fire. So where does that leave you? Right.
Well, question about that. At any point, if you develop that and you are just a premenopausal woman and you have just estrogen circulating,
right,
you're lighting the gas up,
Sure. Yes. Yeah.
So it's not more. You might be getting back to that baseline risk that any woman has if she suddenly develops an estrogen receptive cancer. No? Or is it more? Is she more?
Well, she's more at risk of getting a second breast cancer than, say, another person getting cancer in the first place, right?
Right, because
so breast cancer is just 1 in 9, and maybe her risk of getting a second breast cancer is 1 in 4.5 because she already had a cancer.
Okay.
Anyway, again, theoretical, and I have, it just all has to be an educated discussion between you and the patient. These are the truths. This is what we know, and these are the risks. And
that's everything, right? Like everything needs to be a risk reward conversation.
Totally.
Right. And I love that so much because that's true for everything. I mean, it's true. I was just having this conversation with someone and I was like, something like milk has different, some people who could tolerate it, some people are a mess, and people in between. And so like you can have a risk reward conversation about milk. You can have a risk reward conversation about gluten. So we need to have risk reward conversations also on vaccines. We need to have we need to have risk reward conversations on just Tylenol. Some people, like everyone's different, right? People take Benadryl and they'll go to sleep. Some people are hyped up. Some people don't feel anything. Risk reward, everything. So I love this conversation. Like what you're saying is, yes, amazing. Most people probably fine, great, but there is a subset of population that we also shouldn't just say no to.
No, of course not. Everything is a risk reward.
A risk reward. And that woman you just described might say, you know what? I am so miserable. My marriage is going to hell. I haven't had sex for so long. I'm ready to kill some people. I'm willing to take that risk.
Right.
Especially understanding that she didn't cause it. Like if she was going to get it, she's going to get it. She maybe needs to increase her surveillance, maybe be more vigilant. But that is such an empowering. Someone must say, you know what? I'm good. I don't even feel so bad. Don't go through that chemo situation again. I mean, what a great conversation to have.
Yeah. And you know what? I think the big differentiating factor is our age and our generation of who are now doctors and physicians in this whole renaissance of menopause, so to speak, because we're not paternalistic physicians anymore. Now we are empowering our patients, right? We are putting the decision process right in front of them to make the decision with us. We're not telling them what to do. We can give them our suggestion, our recommendation, but at the end of the day, they have to buy into it and decide what's right for them.
That's a really big deal. Shared decision-making is so important on everything. I mean, I do it even with like blood pressure medication. Like, let's talk about this together. Like, what do you want to do? You know, people are so worried about medication. And I'm like, okay, well, we're worried about the stroke also. And let's just have the conversation. Yeah. And I love that shared decision-making, everything. And you're right to surface that that is more of a feminine approach to medicine. We are by nature collaborators. We want you to hop in. We want you to feel like we're doing this together as a team.
Yep.
More team oriented, as opposed to like, this is what I said, how dare you question me?
Absolutely.
I love that. That is true. That is, I considered but didn't put into words that as more women get into medicine is just changing because we are bringing our feminine energy to this. That's huge.
It is huge.
We're so cool.
We are. Now all you have to do is fix the whole insurance, medical insurance, healthcare system, and then, we're good.
Yeah, that should be easy. Like, I think we're like in an hour.
Wrap that up by next week, right?
Yeah. I mean, if you want to give it a week, that's fine. I was going to do it in the next hour. But I mean, if you want to move slow, that's fine. That's amazing. Okay, that was really good. And it's also good for those who are overly scared, because some people are just overly scared. Like, what, you never had cancer. Like, it's not true. So I think just you taking the moment to explain to us who are the people that really need this conversation already takes away, like, I don't know, a huge population, I don't know the percentage of women who don't even need this conversation. Just go ahead and do it.
Yeah. Yeah. Well, and if it helps your listeners at all for their confidence level, my mother had an in situ breast cancer, but I'm not significantly at risk, I don't think, or I'm believing that I'm not. And I'm using hormone replacement therapy.
I know it. It's so light.
And I'm an oncologist.
Well, that's a big deal.
That's why I'm outing myself.
Well, that's a big deal, because one of the reasons I never got LASIK surgery is because my eye doctor wears glasses. And I'm like, sir, if you're not getting it, I'm not getting it.
There you go.
Here's an oncologist telling you she does HRT. That's a big deal.
That is a big deal.
That is a big deal. Thank you for outing yourself.
Can I add one thing, though? Because I didn't mention this, and I always feel uncomfortable that I don't say this. For triple negative breast cancers, up to 70% of them actually have on the outside of them a fourth receptor called the androgen receptor, which binds to testosterone.
Fascinating.
Okay? So the reason I bring this up is that, okay, we just said triple negative breast cancers, we think it probably is okay for them to take HRT, and we had that conversation and the patient makes their decision. I'm not so comfortable giving testosterone therapy if I know, especially if I don't know if the androgen receptor was present or not on their last cancer. It's now become routine to check for that androgen AR receptor. And so patients with triple negative will know if they have that or not. But what if you don't know? And what if you're putting testosterone into the system that could potentially be fueling this triple negative breast cancer? Boom.
God. Boom. That was necessary. I knew that.
Yeah.
That is a big deal, because how many people really think like it's just estrogen?
It's just testosterone. It's just testosterone. And I'm not a man.
Yeah, no, I mean, like, everyone's scared of estrogen, but I don't think anyone's scared of testosterone like that. That's fascinating. I'm so glad you surfaced that for us. Again, testosterone is safe for most people. Except
for most people, and it's a dose issue, and I'm just saying that no conversation when it comes to cancer and HRT is really all that straightforward or simple. And there's so many nuances to it. And it's, anyway.
I love that.
We killed this one.
Because when you started explaining this, you said oral hormones, like, as opposed to vaginal. But what about topical?
Topical. Well, I like topical the best. So I personally, again, I'm using a topical estradiol.
But risk factor, because when you were talking about the risk, you were like,
right,
we really are concerned about oral hormones. You were careful to say that versus vaginal. Does topical carry the same risk as oral?
So that's a great question. I think part of the difficulty in teasing apart that question is the fact that we have never done all those studies that were done back in the early 90s, the turn of the century. We're not done with modern bioidentical hormones that are present that you can utilize topically, for example. I think that progesterone, for example, is definitely more toxic than, bioidentical micronized progesterone, because it's a different drug. It's a different hormone than your body makes. And so you can't even compare them apples to apples.
I just want to take a moment that you said the 90s was the turn of the century, and like reeling from that, because I graduated high school in 1990. And so, like, I don't even know if we should be friends right now, because I'm still processing turn of the century. I'm like, what? Turn of the century was yesterday. I graduated high school yesterday. Sorry.
Right.
Sorry.
No, you're right.
So micronized progesterone. I'm sorry. That's where I got stuck. Okay.
Well, they always say, like, when you talk to somebody that's, I'm a Gen Xer, right? And you say, oh, 30 years ago, I'm thinking in 1970.
I know. That's a delightful thing. Sorry, listeners. He's listening.
But we digress.
And we digress. But okay, so to your point, anyone who didn't get this part, micronized progesterone is what we're giving today with HRT. That was not what was studied.
Right.
So it's not just oral to oral. It's like a whole different medication. But actually, I'm not a big fan of giving oral estrogen in general. I like it topically. But so you're saying we don't really know. We could have different data.
Absolutely.
But
different drugs.
They're different drugs.
Different
drugs. Not being processed the same way.
Absolutely.
It doesn't have to be detoxified the same way. It doesn't have to be conjugated the same way. Can we infer that there is would this be dangerous to infer or assume, I should say, not infer, assume that there's slightly less risk considering what we know about vaginal estrogen?
I think given what we know about the fact that the usual estrogen that's in our bodies, our natural estrogen production, does not in and of itself cause cancer, right? Otherwise, you would see many, many more hormone. Everybody that gets pregnant would have breast cancer, right? Because your hormone levels would be through here.
Oh my God. But say that loud.
That's not the risk.
Yeah.
Yeah, right. So that's not the risk. So I think based on that specifically, I think that bioidentical hormones are probably safer because they are our own hormones as opposed to, the horse urine estrogen that we used to be making. But truth be told, and you heard it here first, this is not going to be decided based on another one of those studies where they put 50,000 people on this hormone or that hormone and follow them for 10 years to see if they get breast cancer. We can't do studies like that anymore. We're not going to get the data that we need in enough time. And we have enough technology now that this should be decided by the DNA. So there are tests that we use, for example, in breast cancer. One of them is called Oncotype, okay? And the Oncotype takes a piece of the tissue from the tumor, and from it, they run a set of 20 genes, and they can see whether or not those genes make the cancer more or less responsive to estrogen or more or less responsive to chemo. And so we use this test in early stage breast cancers to decide, does the patient need chemo or can she just have hormone? And it will actually give you percentages of risk that are pretty accurate. And there are multiple other tests. There's another one called Breast Cancer Index and what have you. I don't want to go on and on about that, but we have the technology and the ability to measure different levels of estrogens, to measure how your body metabolizes the estrogens, as well as what your tumor really wants or needs. So for example, if you have an estrogen receptor positive cancer and you have a very high oncotype, which means that it's less estrogen responsive and really needs chemotherapy to get rid of it, patient still goes on anti-estrogen therapy, but they get chemo. So now I know that tumor is less estrogen responsive. Is that patient safer to get hormone therapy later? See what I'm saying? I don't have the answers and I don't have the test in my pocket, but if you know somebody who wants to develop it with me, let me know because I'm on it.
No, this is wild because you said so many things. Essence, it almost makes as we get better with DNA and precision testing.
Yep.
This idea of this randomized controlled study across, I'm not throwing it out, right? But I know it almost feels antiquated because
100%. I don't even want to read those studies from 1999. They're ridiculous. They don't have any applicability here anymore.
Yeah, but I'm just saying, even just taking a group of women, it's not really enough to take a group of women because you have to take a group of women with this particular DNA.
Right.
So it's not even the data's not even. It's because you just you need an N of one. What's going on for you?
Right.
What's happening for you with what we know about the activity of the cell?
Yep.
That changes. That's actually mind blowing.
Yep. Functional genomics,
precision. This is the ultimate precision medicine.
Yep.
And then it's interesting because the technology exists in order to determine treatment, but we could take this technology to determine, not just treating the cancer, but how to manage you post
Yes.
That's
Absolutely.
That's earth shattering.
It is. Now that I said this on your big podcast, somebody's going to go out and do it, but oh well. I'm an idea maker.
And it was original idea here.
Right. You heard this by me.
Dr. Troso to make sure that she's on that council or else.
Yeah, sure.
I'm good right here.
Right.
Oh my God, that is big. That is big. And the repercussions for studies in general with something like this is crazy.
Yep.
Oh my God, what a mind-blowing moment. Okay. This is so good. As we get to our top of our hour, what do you want to tell our audience?
Okay. I want to say that, assuming that your audience is also patients, right? We're not just physicians.
Yeah. I think it's the clinicians are hiding in my audience at this point.
They're hiding, but they're there.
Out. They're trying to figure out, do we want to do functional medicine? Can we jump? But anyone who's here is here because they're searching as a patient.
So my thought I want to get out to the whole world is that you need to put yourself first, particularly if you have a serious illness like cancer. There's no time for you to be second fiddle, that you need to understand that if you have a serious diagnosis like cancer, you must come first, and that you need to help others to help you. So we have always been the caregivers. Women are the focal point, the rock, the one that everybody else leans on. And there's a time, especially when you're fighting cancer, that your life is at risk. And so you really need to make sure that you are taking your needs seriously, and that you are making sure that everybody else understands that they're going to have to pitch in here, and they're going to have to help row the boat while you are getting your treatment and getting yourself healthy. And that's psychologically and physically.
You got to put the oxygen mask on first.
Exactly. That's a good analogy. You got to put your own oxygen mask on first.
And I know we didn't talk about this, which is crazy because you are like the ultimate patient advocate, and we're talking about really cool stuff. So I'm sorry that.
Well, you'll have to have me back then.
Yeah, I'll have you back. But like anyone who's listening, if you're dealing with breast only?
No, gynecological also.
GYN cancers, or know someone. You need an advocate. Well, let me start here. You cannot do this alone. You need an advocate. I tell my patients all the time, sometimes like, oh, I went to the hospital and they didn't. I was like, you can't send grandpa by yourself. You need an advocate. This is just how the system is. Nobody's bad. Nobody's malicious. The system is not going to listen to you unless there's an advocate. So first and foremost, don't try to do it alone. It's not happening. So if you're going to get an advocate, in addition to your amazing support system, if you're lucky enough to have one, you need to call Dr. Troso, because to have someone who understands the lingo, translates it to you, and be able to give you like I just learned so much in this hour. I can just imagine if you're contending with something the service you're providing this world is huge.
Yeah. I have a gift. I have a gift for your listeners too.
Ooh, tell us.
So you have to text the word cancer to 516-271-4114. Okay. 516-271-4114. And then I'm going to I have a great PDF that I send out to everybody that's all of the most important questions that you need to ask your doctor.
I love that. And that cell number, if they're like, how do I reach you? Can they text that too?
Yes, because once you text that number, you'll get onto my email list as well. But you can also reach me on my website, which is winningthecancerjourney.com.
I didn't ask you one question, which I need to ask you. Your personal journey when you left and decided to do this.
Oof.
Did everyone think you're crazy?
It's a complicated answer because I had my own medical problem first that led me to go out on disability for a short period of time. And it was that time that I actually stepped away from the practice. Other than having a baby or my knee replacement, I had always been go, and working. And so once I stepped away for a couple of months and really took a deep breath and smelled the roses, so to speak, I realized I had an epiphany that I can't do this anymore. I almost have like PTSD from working there, to be honest with you.
Yeah. And I'm glad that we had a moment to surface this, because again, everyone that comes here is clinically trained and something happens to them. And it is in that moment that it's the only time in that moment where we could take it and be like, what am I doing? There's more. Because other than that, right, we're kind of like in the Kool-Aid, we're drinking the Kool-Aid, we're doing the thing, we're in.
Doing the thing, day in and day out.
We don't have time to think about it, really. When do you have, let's have a philosophical conversation. And you have to put food on the table, like, and this is what you're trained to do.
Right. Yeah.
So it takes a jarring moment. And while I'm sorry that you went through that, I am so thankful because you are now helping hundreds of thousands of women thanks to this moment that you had. So, like I'm always thankful for my wife's health issues because that's what got me to the dark side. So, it's also reframing.
I'm not familiar with that story, but I'm sorry to hear that. But is she okay now?
No, she's okay now, but thanks to functional medicine. That's how I discovered functional medicine. And then
interesting.
I never went back. So I just went deeper, and every year I find myself more in the vortex. I can't even see the light anymore. So Dr. Troso, we probably should have you back to talk about the journey a little bit more. But in the meantime, anyone who's listening, please reach out to Dr. Troso. It was such an honor to get to know you. You've taught me so much, and I'm sure.
Oh, wow.
Oh my God, taught me so much.
Of course. Thank you.
Thank you for being here.
Thank you for having me. This was really fun. Thank you.
We'll talk soon. Okay, that's a wrap for today's episode of The Medical Disruptor. If this lit a fire in you, good. I hope you're agitated. That means you're waking up. Share it with a fellow disruptor. Post it, tag it, text it. This is how the movement grows. And if you want to wear your disruptor badge loud and proud, head over to drefratlamondre.com to grab the latest merch, my book, and more tools to help you reclaim your health and your power. Until next time, be a medical disruptor. Keep questioning and keep disrupting.